to welcome all currently 83 of you to the fourth Symposium on Global Health Policy Research. This is the first panel after our amazing opening plenary last week. So the symposium is running most Tuesdays between October 20th and 1st of December. Go to the next slide. Just to kind of orient everyone of what this is and how you got here. This is the fourth in a series. So the first two, 2016 and 2017, were at the American University in Washington, DC, and it brought together social scientists from just DC area universities. And after their second one, that group sort of said, why don't we try to go global and involve a lot more health policy researchers from around the world. So in 2018, they piggybacked on the HSR 2018 symposium in Liverpool and had a day-long event before the HSR symposium. And that brought together over 100 researchers from across the globe. And that brings us to the fourth symposium. We can go to the next slide, which was developed through an organizing committee and of course has turned into a virtual format. So just to introduce everyone to our organizing committee, Karen Greppin is an associate professor at the University of Hong Kong. Erin Malaki is with the African Constituency Bureau for the Global Fund. Marsha Orgill, who is the co-chair on this session, is a senior researcher at UCT. I'm Kerry Scott, associate faculty at Johns Hopkins and an independent researcher. Jeremy Schiffman is a professor at Johns Hopkins University. We have Stephanie Top, all the way bringing in the representation from the far time zones in Australia. Thanks for coming late at night, Steph. She's associate professor at James Cook University. And we have Catherine Ann Velez-Rees, who is assistant professor at the University of Manila. Also staying up late for this, so glad you're here, Kathy. And finally, we have to thank Fong Trong, who is a post-baccalaureate fellow at Johns Hopkins University, who has done all the background IT support and has helped us make this possible. Thanks, Fong. You can go to the next slide. So if you want to know more about the forum and the upcoming panels, please do check out our website, globalhpr.org. And you can also follow along on Twitter and tweet about our events at globalhpr. Okay, next slide. So we want to thank the sponsors for the event, the Johns Hopkins Alliance for a Healthier World, as well as the SHAPES Social Science Thematic Working Group within Health Systems Global. Both sponsored this event. Next slide. So just to flag what's coming up, we have panels in the future that you can register for, and you can learn more about them on the website as well. So if you're enjoying this one, there's lots more coming. Next slide. Okay, so just to do some housekeeping, we were hoping to have a bit of a sense of community building, which we would have achieved in person if we'd been able to meet. So we thought if you would feel comfortable, use the chat, and some are already doing it, to introduce yourselves. So you can just mention your name, where you're logging in from, any affiliation you want to share, just so people know who's here. You might find out that a long lost buddy has tuned in, so you can find them. And so use that chat section of the Zoom platform for any reflections, discussions, any comments. You can have side chats with people. Just know that it is all being recorded and downloaded as metadata. So side chats are not fully private. Also note that if you're trying to message people, you're automatically set to being only writing to us panelists, which is nice. But if you want to introduce yourselves to everybody, just switch your to bar to be panelists and attendees so everyone can read what you're saying. We're also going to have a Q&A section. You can find that at the bottom of your screen as well. And that's for posting a more set question that you want to pose to the panel. And you can also see other people's questions, and you can use the like button to kind of upvote questions that you also would like answered. And Marsha will be managing that Q&A, and she'll put together common groups of questions and sort of reframe them if necessary to ask them to the panel so that we can handle as many as possible. So we won't necessarily pick the questions fully formed as written, but sometimes we will, and sometimes we'll combine other people's questions to make one question. Oh, and I think Daniela noted that there's also the hashtag for the event. So hashtag global HPR on Twitter. So today we're going to have our first 30 minutes will be the 4 presentations from our incredible panel, and then we'll have a full hour for questions and discussions. So this looks like a good program. We can go to the next slide. So this is now our first panel, who is heard and silenced in health policy making. And we'll be hearing from 4 incredible researchers representing different regions, and they'll go in the same order that they're listed here. So we'll have Arima Mishra, who is a professor at the School of Development, Azim Premji University in Bangalore, India. And then we'll hear from Daniela Rodriguez, assistant scientist at the Department of International Health at Johns Hopkins Bloomberg School of Public Health in Baltimore. Third, we'll have Inayat Singh Kakar, who is an independent consultant and did this work while she was at the George Institute for Global Health in New Delhi, India. And finally, we'll hear from Tanya Jacobs, who's a PhD candidate at the School of Public Health at the University of the Western Cape, and an independent consultant in gender and health systems in South Africa. Without further ado, we can proceed to the next slide and welcome Arima to start us off. Thank you, Arima.
Thank you, Kerry, and hello, everyone. So at the outset, let me kind of say that I present this on behalf of my colleagues, Veena and Maya, I think, who are part of the audience as well. So next one. So what I'll do is that I'll take you through, sharing our experience of doing research on the role of professional medical associations in health policy making. While it is acknowledged that they are an important set of policy actors, particularly in the low and middle income countries context, research evidence on the sources of power, how do they exercise power, the nature and extent of influence across a range of policy cases is actually, few and limited. And our research actually spoke to this particular context. The next one. So what we did is that we specifically tried to examine the role of the oldest and the largest medical association, that's an Indian medical association, in one of the very specific set of recent policy reforms. Recent means 2018, and the policy reforms actually was about amendments to an existing act which tried to strengthen the accountability of the private sector in one of the states in India. And as you can see in the slide, this was a highly contested policy case that drove thousands of doctors to the street, vehemently opposing, striking and opposing the specific clauses of these amendments, trying to portray that this is a draconian law. While on the other hand, the government is trying to assure the public, saying that no, the amendments are not diluted, we are not really coming under the pressure of the associations, and yet trying to tone down certain clauses of the amendments and finally passing the reforms. The next one. So the reforms were passed, but not without really witnessing, highly complex and messy negotiations among these different sets of actors. And I really want to kind of highlight one of the things when we're talking about policy actors is that, we wanted to understand, assuming that the largest and the oldest, perhaps the medical association must have played an important role in this particular policy. But soon, early in the research process, we realized that it's not the Indian Medical Association, but many, many different associations which played a much more important role in certain parts of the policy process. So it was important to understand the dynamics among these associations themselves, which are very, very critical. And the dynamics and the tensions among these associations were articulated at different periods of the process differently. Sometimes it's government versus private, sometimes it's the association of doctors versus associations representing big hospitals, associations representing small clinics and hospitals versus corporate hospitals. Similarly for the government, kind of as an actor, while of course the role of bureaucrats was important, actually what really was critical and significant, which had an important impact in the policy outcome and the deliberations and changing the completely power dynamics, is the role of individuals. In that sense, the then health minister, who played a very, very important role. And similarly for the civil society in terms of the health activist network and others. And media was an important site for these narratives and counter narratives and claims and counter claims in terms of the intent of the reforms and the content of the reforms. Next. So interestingly, what happened is that this is only a period in that sense of trying to draft the reforms and approving the reforms. That particular 1 year of this policy formulation witnessed, the power dynamics among these different policy actors kept shifting. So while in the initial stage of the policy process, in drafting the amendments, the dominant influence of the associations was quite visible, vis-a-vis the government representatives and the representatives of the civil society, but not really without frictions among the medical associations themselves. As I said, these frictions were largely in terms of whether the reforms actually trying to protect the interests of the corporate hospitals, or it's about, the small hospitals. So whether it's about profit or it's about service orientation of the medical professionals. A lot of these kinds of articulations were brought to the table during the deliberations. Yet, on the other hand, while the amendments were actually passed and presented to the government specifically, represented by the then health minister, overrode the power of the associations and brought back highly contested clauses of the amendments. And the civil society's lobbying efforts and their position really aligned with what the government was trying to introduce. Not that the government and the civil society in that sense are traditional allies, particularly the health activist network, but here the position really kind of was aligned, articulating broadly that the objectives of the reforms were pro-poor and pro-citizens. Next. The lobbying strategies of the associations were critical in trying to shape the deliberations and the final policy outcome. So after, the government reintroduced certain kinds of clauses, the medical association went out in trying to deploy different kinds of strategies. Some of these are what we call inside lobbying strategies, creating a WhatsApp group saying oppose this particular act and circulating widely, to kind of negotiations and forming coalitions of convenience, which are much more fluid, and also building informal networks, two highly visible kind of lobbying strategies, and that's the strikes. The strikes were very important because it shifted the power dynamics in favor of again, the Indian Medical Association, which led the strike. But also what this strike did is that it could bring about all associations together. In that sense, all frictions, all tensions, all internal dynamics among the associations themselves were put to rest, and the strikes could actually orchestrate a consensus across associations saying that this is a united policy stance to be able to oppose the reforms. What also kind of notably that happened is that the strike and the way that they were trying to lobby completely changed the narrative from reforms which was trying for a patient-centered, responsive quality care, to reforms which are trying to unduly attack doctors and a very, very vulnerable, over-regulated medical profession. Yeah, next. So what is it that kind of, this particular policy case study allowed us in terms of our understanding, enrich our understanding? One of the things that we realized is that, existing theory, particularly on the role of medical associations in policy making, which are largely kind of informed by evidence from the high income countries, did not really allow us to accommodate the kind of complexity of the way that the associations actually played their role in this particular case study. So there was porosity in that sense. Everybody is a member of the Indian Medical Association, yet member of some other association, and this porosity was very strategically evoked in that sense. On the one hand, there is porosity. On the other hand, there is fragmentation. with their own kind of internal politics and power dynamics. Yet the lobbying strategies, a mix of insider and outsider lobbying strategies, also could very successfully bring all these very different associations with different interests on a common kind of forum, saying this is about medical profession. And interestingly, in these, though these entire amendments were about the private sector, the government associations, though they were not visibly there, they provided actually moral support because this is about the medical profession. And the insider strategies also in terms of the coalitions, unlike what we would kind of imagine to be much more organized and structured, were highly fluid, even during the course of one policy process, that they really significantly differed in terms of who is being able to exercise power. Another lesson that we learned is that they did exercise power. The sources of power actually varied from technical expertise, which is well known, to actually, collective strength. In that sense, through the strike, they could actually show that kind of collective strength, numerical strength, a historical legacy of an association, which was evoked at a certain point of time, with kind of individualized leadership in some sense. So the sources of power were different. Yet the exercise of power of associations was not something kind of one could assume, and constantly had to be negotiated. It was so much linked to the role of the government, including specific individuals. And here we're talking about, the role of the health minister, and as well as civil society. So what it could actually tell us, that it really defied any kind of predictable nature and pathways of influence of associations in policy making. So, we felt that what we need is actually much more theorization that is informed by, empirical insights from the low and middle income countries, which could actually, allow this kind of, complexity to take into account. Thank you.
Thank you very much, Arima. I was living in Bangalore during a lot of these strikes, and so it's really exciting to see that you and Veena and Maya have been able to kind of grapple with all of the data and different power dynamics to make sense of what happened. So thank you so much. We'll now move on to our next presentation. Daniela will speak about unpacking political will and commitment for vulnerable populations. We can advance the slides.
Hello, everybody. Okay. Thank you so much for the invitation to be here today. I'm presenting on behalf of my co-authors, Christina Potter and Aziz Sandhu. And as Kerry mentioned, I'm going to be talking about unpacking political will and commitment for vulnerable populations, looking at both theoretical and empirical literature. Next. So we've all seen it, right? You're reading your, journal article or the report about some population that needs more attention, or a program that's underfunded, or something that needs more political priority. And there's always that throwaway line of what we need here is more political will and commitment for whatever it is. And so what that prompted for us is this underlying question of, what does that actually mean? Next. The core driver of what we're looking at here is, what do we actually mean by political will and commitment, and what are the underlying mechanisms that could ensure continued support for vulnerable populations? And so the work that I'm going to be presenting here draws on two streams of analysis. Next. The first is a literature review that we conducted looking across multiple development sectors. Our sense was that if we're talking about this in health, we have to, there's probably these same conversations going on in the development and other development fields, like in education, agriculture, transportation, so on. So we cast a pretty wide net with this literature review, and we ended up identifying about 200 articles that addressed political will and commitment. And there were all kinds of different populations represented there: people living with HIV or with disabilities, migrants, refugees, ethnic minorities, indigenous, all kinds of different groups. And what we can see is that these populations are vulnerable, not necessarily because they're, children under 5 or pregnant women, which is how we often think about vulnerability, but actually they're vulnerable because of political issues. So either who they are or behaviors that they engage in, that creates their marginalization. But as we delve deeper into the literature, we find that actually still many articles are talking about things in relatively generic terms. So what I'm going to be talking about later are the ones that actually got into more of the nitty-gritty. Next. The second piece of this is talking about a case study I've been conducting in the Dominican Republic, looking at government accountability for HIV prevention. And what you need to know is that about half of the HIV response in the Dominican Republic is funded by donors. But actually, donors fund over 90% of prevention. And that's going to be important later because government funding covers antiretroviral treatment. But the Global Fund, which is the biggest donor in the Dominican Republic, their support is ending next year when the country graduates from eligibility. So that's putting the prevention funding it's highlighting the issues with prevention funding. Next. So looking at the themes emerging from the literature review, we see a consistency around political will and commitment requiring action. In some literature, it's implicit, and others, it's explicit. But we see inconsistency on a couple of points. One is on whether funding is actually a necessary component or not. Some think it's mutually reinforcing, but not required, while others see funding as being a critical subdimension or subcomponent. Next. And that kind of vision is exemplified by the work by Gore, Fox, and others that break down political commitment into expressive commitment, institutional commitment, and budgetary commitment, where you want to see an outward expression of support for whatever the program or population is, the institutional structures to actually be able to deliver on that expression, and then the funding allocations that go with it. Next. But in the policy readiness literature, we see something come up around needing to have an explicit desire to address the issue. And next, this is best encapsulated by Melina, who talks about how you have to have three things at the same time. The power holders, which are their terms, need to want to do something about the issue. They need to believe that they can do something about the issue, and they need to feel like they must do something about the issue. The other piece that remains, I'd say, incompletely thought through is the role of context. Next. And it's not clear to us what exactly that role is playing and that we've parsed that out enough. Next. So what I'm presenting here is an idea about how we capture some of these ideas together, a vision for how we capture these ideas together as you move from intent to action. And you can see here, we've overlapped expressive commitment and want, because we see those as being relatively similar, with the must feeding into both expressive commitment and to budgetary commitment. And then between want and can, we've broken that down, trying to sort of explore what those pathways are and using budgetary commitment and institutional commitment as the way that you get from want to can. But the part that this picture doesn't really capture is something that comes up in the literature as well, is the idea of needing some sort of force to push to action. Next. So how do we capture the external forces like donors, donor pressure, civil society, like Arima was mentioning, or internal forces like reform-minded bureaucrats or political considerations that may be exerting pressure on this system? Next. So using this vision, let's talk a little bit about HIV in the Dominican Republic. Next. So there is outward commitment, public support for HIV program from key stakeholders across the board for all kinds of key populations. They call them priority populations. So the expressive commitment is there. Next. We see that the National Strategic Plan for HIV is comprehensive. It's budgeted. It includes activities for 10 priority populations. So again, we're sort of heading in the right direction for what you would like to see. Next. The challenge is when you look at funding. So treatment, widely available and essentially funded by government. But when you look at prevention, there's a persistent funding gap of about $18 million a year of the National Strategic Plan. And some key population activities are completely unfunded year on year. Next. So what we captured is that there is pressure from civil society and from global and local commitments to providing ART. They're feeding into this must, not only into how it connects to expressive commitment, but to making sure it actually happens. Next. But the part that's breaking down is that there's limited accountability on this National Strategic Plan, on the funding and implementation of the rest of it. And so there then ends up being a breakdown between what they say that they want to do and then what actually is done. Next. So in closing, a few thoughts to take away. One is that issues of political will and commitment apply to a broad swath of population groups. That's not really surprising. I think we all can think of at least one group in every single one of our communities that would be considered vulnerable under these conditions. Second is that intent is important if we want to reflect on a government's active choice in the program that they support or not. And inaction is also a sign of will. External and internal pressure play a role. How do we capture that? Is it something in which sort of that system, that dynamic, it sort of sits in and kind of stews in external pressure, or are they sort of separate points that come in at different separate streams that point at different points? And the last point is that all political will and commitment is not created equal. So strong commitment in one space, whether for a specific program or a specific population, can obscure sometimes intentional weak commitment elsewhere. Next. With thanks to everyone here for the opportunity to present this, and on behalf of Christina and Aziz, who I know are online, as well as our collaborators in the Dominican Republic, thank you.
Thank you, Daniela. That was fantastic. And it really shows the value of a powerful framework to actually help parse a complex problem and identify areas for where different types of action make a difference. So we'll now move on to Inayat, who will speak about intersectionality-based policy analysis on transportation in India.
Good evening, everyone, and thank you so much. So I'm presenting also on behalf of my colleagues, Margaret Pedden and Jagnoor. So just to give you a context, this policy analysis was undertaken as part of a larger seed grant by the George Institute for Global Health, and other components of the grant included 2 qualitative studies from the perspective of gender and disability, which were exploring people's experiences and challenges with access to transportation. So I'd like to draw upon some of these while we are discussing the findings of the policy analysis. Next. Thank you. Why transportation? So as we all know, the Sustainable Development Goal 11 talks about sustainable cities and communities, and one of the targets under that is to address the need for sustainable and affordable transport system with special attention to the needs of vulnerable populations. And transportation is also a social determinant of health. And I'm not going to go into the definition, but we know that social determinants of health over the years have been enshrined in various documents, from the Alma-Ata to the WHO Commission on Social Determinants of Health, and to more recent recognition of the same during this COVID-19 pandemic. And transportation is actually unique because it's a social determinant of health, and it also enables access to other social determinants of health. So being transport disadvantaged actually contributes to inequities, as it means exclusions from socioeconomic opportunities, and therefore it becomes an important determinant. Next. Thank you. So to go into intersectionality, so intersectionality is primarily a political theory. It birthed from the Black feminist movement. And, this theory explains that a person's experience cannot be understood or explained by considering a singular aspect of identity, whether that is gender or sexuality or ability. And it states that our experiences are shaped by our social location, which exists at the intersection of many identities, as you can see in the diagram. And then this social location is then influenced by systems of power, such as classism, racism, sexism, ableism, and these are then influenced by the institutional and policy context. So I think what intersectionality really brings out is that there are marginalizations within marginalizations. So for example, to talk about the development of the theory, Black feminists were raising the question that the experiences of Black women are not the same as those of white women. Bringing it closer home, we see that in India, when we talk about gender, the intersection of caste or disability creates unique disadvantages, and it's often overlooked. So intersectionality focuses on representation, it focuses on power, and I think therefore it's a great framework for researchers and also for people who work on the intersection between, of research and practitioners. And intersectionality encourages us to look at who is included, and more importantly, who is included. So to look at these marginalizations within marginalizations, and also to look at the interaction of the personal with the structural. And therefore, it's a powerful equity-informed tool, especially for analyzing public policy. Next. So the questions that we were asking when we were doing the policy analysis is, that how are identities constructed? So how do policies look at population groups? Do they look at them in boxes, or is there a recognition that there is a diversity within each group? Then the second thing we were trying to understand is that what are the assumptions that are made about these groups? So what is the evidence that is brought on board? What is the evidence that is considered? And this again directly relates to how identities are constructed in the policy documents. And then we were looking at, what are the needs that are addressed in the whose needs are addressed in the policy documents, and where is the focus. And the fourth thing we were looking at is, who is at the table when policy decisions are being made. And who is at the table, who is being consulted, and who is involved in the negotiation for the policy development. And our guiding principles were, we were looking at whether the policies state explicitly the above, whether these are available visibly in the policy, or you have to sort of dig through and make assumptions, and and are these articulated, and also if the policy documents contribute in any way to stigmatizing the very communities and the population groups for whom the policy documents are made. Next. Right, so we analyzed 26 national level and 8 Delhi level policy and planning documents. I won't go into the methodology of going through these documents to even narrow down to these 34 documents. And I think Kerry has a question on that, so maybe I can come back to that later. But our key findings were, one, that construction of identities is narrow, it's unrepresentative. So broadly, there is age, disability, gender, and income is what was articulated in the documents, but the construction of each of these was extremely narrow. So for disability, it was only physical disabilities that were really focused on, and we have the Convention on the Rights of People with Disabilities, which was adapted into law in India, and the law recognizes 21 types of disabilities, but overwhelmingly we found that the focus is on physical locomotor disabilities. Only I think only about 4 documents talked about visual and hearing disabilities. When it came to gender, we found that the construction of gender is again very limited. It's only women that are talked about, and there was a complete absence of recognition of LGBTQIA populations and their concerns. So what we found is that while equity is a consideration in these documents, the equity concerns are not explored fully. Then policy solutions prioritize infrastructure creation, but don't address the softer issues of transport challenges. And I think this is again, it is significant because we see globally that there is, an overall neoliberal push for policy and program development, and the same thing is reflected over here. So to talk about some of these softer issues, during the qualitative studies, we found, people with disabilities were articulating attitudinal barriers that prevented them from accessing transport even when infrastructure was available. So, for example, if there is a ramp that is available to get into the bus, the ramp will not be opened. Women articulated that if they were the only one standing at a bus stop, the bus driver will not stop for them. Among the LGBTQIA participants that we interviewed, a lot of them spoke about how the very binary lines, in Indian metros, where you are checked and searched, so the lines are very binary, and this triggers a lot of dysphoria in them, and also impacts their mental health. So on days that they have important presentations or meetings, they actually choose to not access public transport and instead spend more on taking a cab or something else. And so these are the softer issues which were not addressed. We also found that safety was sort of the primary concern for women. But when we interviewed LGBTQIA people belonging to the community, a lot of them said that for us, if we are standing on the road and we're waiting for a cab, we are often the trans community said that when we're standing on the road waiting for a cab, we are often mistaken to be soliciting for sex work, and it is actually the police who comes and harasses us, and that puts us at risk. And these concerns are not addressed or even acknowledged anywhere in the policy documents. So then the third thing is structural and contextual factors are not considered. So one, I mentioned, that there is like an overall neoliberal construction to policies. And we also found, that there is a lot of push for non-motorized transport. And a lot of that comes from, I think, global discourse. And what we found is that, it's not contextualized to India. I mean, India has a very varied climate, and in the summers, parts of India can get very hot. So when we're only pushing for non-motorized transport, saying that, there are X percentage of people who already use non-motorized forms of transport, the policy sort of overlook that a lot of these people are actually captive users and not people who are making a choice. Then the next thing we found is that primary stakeholders and rights-based groups are generally not included in decision-making processes, and policies don't mention the consultation process or actors involved. Only 4 policy documents out of all of them that we had seen reported on even the consultation process. And over there, we found that the actors were, government officials, domain experts, and industry players. And the social groups that were recognized by the policies as being disadvantaged were also not at the table for the consultations. There was a policy that mandated decentralization and land acquisition, but there were no rights of people whose land would be acquired that were mentioned. There was no talk of including community-based groups that were mentioned. There was only one policy that talked about including civil society, but all of these 4 policies, nowhere were the detailed consultation documents provided. So we don't know what is the discussion that happened. We don't know what of these discussions was included into the actual documents. And I think there's also a sort of tendency to paint civil society as a homogeneous body when it's actually not. There are layers, there are power dynamics within civil society, there are international donor groups, there are community-led groups, there are NGOs, there are researchers. So I think even when we're talking about representation, it's not enough to say that civil society necessarily means representation. Then we found that implementation and accountability frameworks are not detailed, which means that there are no timelines, there are no budgets that are detailed, there are no, actors that are listed out, and there is no grievance redressal or public engagement forum that are imagined in the policies. And we also found that some of the policy documents were actually using stigmatizing language. So, in 11 documents, people with disabilities were mentioned, but out of these, in 5 documents, language such as referring to people as physically challenged or people with special needs was used. And in one of the policies, one of the goals of the policies was to create employment, but the policy document said that to create employment opportunities for all able-bodied Indians. So you can see that there is a lot of scope for these documents, for the articulation in these documents to be more rights-based and to be more, to be more equal in that sense. Next. So the key takeaways are, that how identities are constructed, how population groups are understood, really matters for identification of needs, for bringing on evidence, and then for framing corresponding solutions. Another thing that we found in our documents is that, some population groups will be mentioned in the objectives, but they are not mentioned, when the solutions are being framed, or evidence is not presented to show what solutions have been presented. So there was a lot of inconsistency in terms of who is mentioned in the objectives, for whom evidence is presented, and then for whom solutions are drafted. The second is that there is a greater need for contextual and decentralized planning, and I think this also ties in with involving local groups, of users into the decision-making process. We find that industry players are sort of automatically inducted into the decision-making process, but it's the users that are often left out. The third is the drive of policies must focus on creating equitable cities instead of world-class cities. So world-class cities is a real buzzword, in India as far as urban planning is concerned at the moment. So we need to move from a neoliberal agenda to one that addresses systems of domination and oppression. And there is a need to push for institutional mechanisms for public participation, not just at the planning and decision-making stage, which is very important, but also at the implementation stage of the policy. And lastly, the principle of universal accessibility is again envisioned in a very neoliberal sense of just infrastructure, but there are softer issues that need to be addressed to fully operationalize this concept. Next. Thank you. So I just want to acknowledge the institute under which and the grant under which this research was possible. Thank you.
Thank you very much, Inayat. That was an incredible overview of so many policies that you've managed to go through and pull out the key themes. We'll now call on Tanya to talk about dominant, marginalized, and silent discourses, a gender analysis of adolescent health policy.
Greetings from South Africa, everybody, and thank you very much. I'm really excited about this opportunity and being part of this discussion. I'm going to share some findings and reflections from a paper we recently submitted to Health Policy and Planning, and I'd like to acknowledge my co-authors, Asha George and Michelle de Jong. Next. So to set the scene, the Sustainable Development Goals emphasize that no one is left behind, and gender equality is both a standalone goal as well as a cross-cutting priority. And Inayat already highlighted the issues of intersectionality. So again, the point that gender intersects and compounds other axes of inequality in terms of race, class, sexual orientation, disability. And we also know that health systems, including policy documents, are not gender neutral. So the opportunity we have is analyzing policy documents in a way of understanding how these are socially constructed and how they interact and co-produce social and political contexts. And so what I'm going to share with you today is from a paper of which the purpose really is to do a gender analysis of the content of adolescent health policies in order to explore how gender is constructed and to raise some critical implications for us as health policy analysts as well as praxis. Next. So what we did, we integrated a gender lens in terms of the overall theoretical and methodological approach. Our data was focusing on policy documents by national government, and this layer of government has the mandate for policy development. Our database included 15 key policy documents relevant to adolescent health, and these dated from 2003 to 2018. And we initially did a content analysis describing what there is, as a foundation for a critical discourse analysis, which really focused on what more was implied and what was said in a less explicit way. And importantly, we also drew on Carol Bucky's framework called What's the Problem Represented to Be? And this is really exciting because it allows us to focus on what is problematized as well as what is unproblematized. So what is missing, what is silent, who is left out, etc. Thanks. Next. So just briefly, I see the slides a bit distorted. We mapped the timeline and actors, and we found a complex landscape of multiple actors, multiple foci, as well as complex processes for policies. You'll see some years there were no policies developed. In other years, several policies developed all at once. Next. So for the discourse analysis, I'm going to present some of the key findings. An important message here is that the dominant, marginalized, and silencers coexist, co-produce each other, and create this rich, policy picture of who is heard, what is said, who is silenced, and who's not visible in the policy documents. Next. So dominant discourses construct gender equated with biological sex. So without recognizing how gender is socially constructed and how femininities and masculinities are really social, as well as the relational aspects of gender. Dominant discourses also construct concepts as being the same, so conflating them. For example, gender to mean the same as girls, and these are separate from the social contexts, the power relations, the actors that create these inequalities. The dominant discourses also include fixed binaries. So I think Inayat also mentioned these notions of masculine versus feminine, heterosexual versus homosexual. So coexisting with these dominant discourses are more marginalized discourses, which begin to construct sexual orientation and gender identity, for example, as more fluid, diverse, and non-binary. And of interest, of course, is the silencers. So we identified silencers around, adolescent boys, for example, focus on them in terms of their own health, but also their role in terms of gender power relations. Next. And so related to this, dominant discourses construct adolescent girls decontextualized from the multiple power relations that generate their health. And in this way, we understood this to be as apolitical, so out of power relations. There are also dominant discourses that talk about addressing gender as addressing girls. And again, most of the policy documents construct adolescent health and sexuality as predominantly being about risks and problems, a much more negative framing of health. So juxtaposed to these dominant discourses are more marginalized discourses which talk about adolescents' rights across various spheres, but mostly in relation to sexual and reproductive health and rights. And they also talk about adolescents as being social assets and who can be making contributions and whose voices need to be amplified. Importantly, a silence exists with regard to the inclusion of interventions and programs that address a full spectrum of rights. So a huge silence around sexual rights and a focus on LGBTIQ plus people, just within an HIV framing. So again, a silence beyond just an HIV construction. Of interest in more recent policies, but again, this is contested, is a focus on comprehensive sexuality education. So again, in terms of our timeline, we see this kind of discourse emerging more recently, but in the public discourse, there's huge contestation about this issue. Next. So related to this, across the policy documents, there was a tendency to focus on symptoms of gender power relations. So a huge focus on gender-based violence, a huge focus on HIV, without foregrounding the underlying causal determinants. There was also a very strong focus on targeted treatment strategies, rather than also including prevention-focused and more gender-transformative strategies. Across the policy documents, there was no real attempt to dismantle or critique the social and structural determinants which lead to these symptoms. And also a resounding silence on how we really need to transform gender inequality beyond just providing services, biomedical and behavioral interventions for adolescent girls and young women. So that's a huge silence. This is just very much focusing on the immediate and on adolescent girls and young women. And of course, the impact of this decontextualized focus on symptoms further reproduces the understanding that adolescent health is really the domain of the health sector and really about providing services for health problems. Next. So in terms of our discussion and points we could take further, we argue that broader conceptualizations of gender open up pathways for transformation of power at the micro, meso, and macro level of the health system and also broader social systems. What we've seen through our research is that the dominant marginalized discourses, as well as the silences, produce and reproduce what is problematized and left unproblematized. And this, very importantly, has implications for policy subjects. So who's included, who's excluded, and how that relates to implementation. And I think an important question for us is, as policymakers, implementers, researchers, we really need to ask how very broad, healthy understanding of adolescent health gets reduced to focus on girls, problems, and really becomes decontextualized and depoliticized, so out of the context of the power relations. It's also been an interesting opportunity for us to critically reflect and analyze the relationship between the content of adolescent health policies and the social context in South Africa, and see how they are almost co-constructing and co-producing each other, and at the same time make visible the power relations and the gendered relations in terms of how, the relational aspect of that. So next. So in conclusion, I'll leave you with some thoughts and some points for further discussion. Through our research, we emphasize the dynamic and dialectical relationships between content of the policy documents and the context. And really the important point, again, that policy documents are socially constructed, they're not decontextualized texts. And we have rich examples of that in our paper. And then finally, I would argue that how gender is conceptualized matters. It matters both for us as policymakers, policy analysts, but also how we begin to consider praxis and implementing those policies. And that policies really need to be the foundations for transforming gender and intersecting power relations. Next. Again, so just to thank you for this opportunity and to acknowledge the support. Thank you very much, Kerry.
Thank you, Tanya. So at this point, we can take down the slides and ask our panelists to turn their videos back on. And we're going to move towards our discussion period. We have a few questions that have come in, so thank you everyone for writing in some questions. Keep them coming, and I'll give Marsha a moment to consolidate the questions and look through them. And if we could just kick off with a first question with brief responses from each of the panelists. One thing that really struck me as I was listening is that health policy analysis really requires us to decide what data sources to include. We have so many different documents to draw from. We saw, interesting media coverage that Arima spoke of. Of course, the official policy documents that were looked at, meeting minutes. Then there's who are the respondents? Do you include respondents at all? Who counts as a key informant? And some people use observation as well. Certain meetings and deliberations. Can you access those spaces as researchers? So deciding on your data sources has a political component about whose voices are heard and who you bring in as a legitimate part of your data set, and also practical considerations, because I find there's just a lot of data. There's a lot of things you could pull into a data analysis. So could each of you just comment on some of your decision-making process around what to exclude and what to include as your data sources, any trade-offs you made or challenges you faced in accessing the data that you wanted? Can start maybe with Arima.
Okay. Yeah, thanks, Kerry. That's a great kind of question. Particularly for our research, interestingly, it's not so much the inclusion and exclusion of the data sources, but one of the key set of, in that sense, informants were the government officials, who were part of this amendment committee and who were the very key actors. Unfortunately, it was extremely hard to reach out to them to kind of, get them to speak for two reasons. One is that, even if our study actually took place barely a year after these particular amendments were passed, most of the people who actually mattered in that, were involved in this policy process had already kind of moved to different offices, so they were least interested in talking about it, to the point that somebody who was part of this actually went to a completely different department called Metro, so that became very difficult. They were not really answering. Second point is that they were, this was a highly contested kind of, in that sense, of a policy case. Part of the transfer and moving to different offices also happened because of the controversial kind of policy, outcome. And people were not really willing to talk. So even if we would like to hear them, they didn't want to be heard. I mean, in that sense, it's the really different kind of power dynamics between the researcher. You are really vulnerable because they don't care about you. And this is something which is very, very important, because the state, in that sense, plays a very important role in policy making. And, if you find it so difficult to access, senior state officials, it's very difficult. And what we had to do is that we had to actually reconstruct a story of what the government had to do is through the minutes of the meeting that we had, which, as some of the members would say, that very sanitized version of what was happening actually within the closed doors, and what was actually there out in the media, what the health minister would say, and giving interviews about that, and supplemented with actually those who were relatively accessible is the retired kind of government officials, so we had to kind of construct a story, but definitely we couldn't really reach out to those who really participated in the policy process. Yes, and that was, yeah.
Fascinating, thank you. Daniela, would you like to go next?
Sure. So I was thinking about this question a little bit in terms of, it's more specifically around the work in the DR, less so the literature review, because you include what kind of comes up. So when we were looking at the development process of the National HIV Plan, the PIN, at first, that had happened a few years prior. And so it's, going to be retrospective because we can't attend those meetings as much as we would have wanted to. And the first few people we talked to were it was great. It was consultative. Everything was fine. And we were very skeptical about that answer because we thought that it seemed sort of odd. But it ended up being pretty much what we heard from almost every single respondent. And it seemed like once we and these were folks that were perfectly happy to criticize lots of other things, but they weren't criticizing this process. So we had to reach the conclusion, as unlikely as it seemed, that apparently it had been a rather consultative process. But when we juxtapose that with how the actual plan turned out, it's such an aspirational document, and it includes all the things. So I could see how people would feel quite happy with how it turned out, because everyone's priorities were actually reflected. The real tension came when it came to actually whether the plan was implemented as designed and whether the budget was actually allocated. And that's where folks were actually really critical. And when we would ask people, well, what about the monitoring and evaluation piece that's meant to be a part of this to sort of ensure that things are happening? And they're like, that doesn't really happen. And when we meet and talk about it, it's very, it's very heated, and, but the government's priority is making sure to provide treatment, and you can't disagree with that. So we can't make them take money out of treatment to put it in prevention. And it would have been really nice to participate in those meetings, the ones about where they talked about the results of the monitoring of the plan, because clearly that's where a lot of the contestation was really happening. And the sort of, and treatment always won the day. If you think about every single key population that's represented in those meetings, and they all were, everybody had some sort of representation, they all have folks within their communities who are living with HIV for whom it is critical to receive treatment. So it was kind of an interesting dynamic to see the government say, well, I don't have any more money to give. Do you want me to take it from this? And nobody wants you to take it from this. And so it creates, I think there are questions, and it's very difficult to discern how much of that is a sort of an intentional dynamic that the government is pushing versus a sort of a real sort of lack of, a fiscal constraint. But I just think it was a really interesting kind of development over time. And we tried to talk to everybody, because we were like, this doesn't sound right. In terms of documents and what isn't captured and what is captured, I think Arima's right. I mean, what's in meeting minutes isn't realistic necessarily, but sometimes it also tells you who was actually present and who wasn't present, and maybe that's enough. I will say that, much to my surprise, all different kinds of populations were represented in these meetings. So I don't think that is necessarily an issue, to the extent to which they can, and even that they seem to speak. I think the question is whether it actually changes anything. And I think as a collective, they're not pushing for prevention. And part of the problem now, and I didn't talk about this, but is a real sort of tension around accountability, is that civil society, who had historically been the accountability mechanism on government, now a lot of those non-governmental organizations are recipients of funds, either from donors or from the government in themselves, to deliver services. So once you start being involved in service delivery, it changes your dynamic, especially if the money's coming from government, in terms of how you make demands and how you create advocacy. That's a whole other ball of wax that needs to be explored and that we're trying to work on separately.
Thank you, Daniela. Yeah, it's interesting how the different types of documents you had enabled you to identify where the actual tension points were. And the interviews were actually telling you, like, the consultation was fine. They put everything in there. It's only later that the implementation went wrong. Inayat, would you like to go ahead?
Thank you. So I think, like Arima mentioned, that there's a lot of distance between policymakers and the public. And I think we often imagine that technology is the one thing that will actually bridge that gap. But we actually found that to not be entirely true. So since we were looking at policy documents, which are available in the public domain, we were going through, ministry websites, and, there are tabs and there are sub-tabs, and the way things are organized is not very clear. And usually what happens is that whatever is the flagship program, of that particular ministry, sort of, you'll find those documents, but a lot of the other documents are not there, or they're not organized well enough. So I think we went through about 2,300 to about 2,400 documents. We had to sift through, random things like nominations, like appointment letters, everything to find, policy documents which were relevant and which we could use. So we had to go through a three-step process where we were first looking at whatever is available. Then, we were sort of sifting through to see which of this is policy and planning and which of these are, more day-to-day administrative documents, and then coming on, to which of these apply to our research area. So yeah, it was a bit of a challenge, because these documents are not there in the public domain.
And it's almost another research question about to what extent that is just a limitation, a capacity problem, and to what extent there is sort of a power dynamic in choosing not to make things easily accessible. I know with like key informant, with access to information requests, sometimes it's sort of an active response to sort of kill you with information, just give you piles of documents that you can't process that the government has used. So burying things on websites, not labeling them easily, that could also be, it could be completely innocent and just a capacity issue. It could also be strategic. It's something else to look at. Tanya, would you like to comment?
Yeah, great, thanks. Great question, and building on what my colleagues have said, I think from our side, the data for this paper was intentional, in terms of policy documents, which for us provided a great opportunity for a detailed and thick and rich analysis. But of course, this also has implications and limitations. We really view policy documents as products or artifacts, almost an anthropological evidence, which looks at how these texts represent ideologies, beliefs in the social and political context. And so we framed adolescent health quite broadly, but placed beyond the scope of our analysis, sectors like sports and recreation, agriculture, water and sanitation. So we note that as a limitation. And we also didn't look at, for example, provincial policies, because national government has the responsibility for leading on this. And we also acknowledge that, non-government stakeholders also develop policies. So we really wanted to do a deep dive within the sort of legitimate policies at a national level and really do thick and rich description of those in terms of the discourse analysis. Having said that, I think what we've also noted is that what is missing are the actor voices and the actor interfaces. And so that is a focus of my, one of my next PhD papers, is really zooming in on the narratives of actors and looking at how these actor interfaces shape the policymaking process. So more of the how of how gender is constructed through the processes. So I'll keep you up to date when that's available. Thanks, Kerry.
Maybe for the next symposium.
Yeah.
Thanks, Tanya. Marsha, would you like to come in with some?
Yeah, sure. Thanks, Kerry. And thanks everyone for such great presentations. What I'll do is I'll give 3 questions and then I'll give everyone a chance to respond. So I'm hoping that I'm translating the questions in the Q&A correctly. So Arima, someone's raised a very interesting question about the role of external capacity building of medical associations. It was Catherine, and she says she's from the Society of Obstetrics and Gynecology in Canada. And she's wondering if this external capacity building is in effect enabling medical associations to influence women's health in their own setting. I guess you could comment on whether you think that's negative or positive. So before you answer, Arima, I'll just pose 2 other questions. Daniela, you've got the $1 million question. How do we translate political will into action? I guess maybe I'll reframe that a bit and ask, did you come across any literature that is also trying to theorize or conceptualize or build empirically on the link between political will and action? And of course, based on your own work. And then for Inayat and Tanya, there's a question on how can we make life easier for policymakers in the sense that it's not an easy task to write a policy that takes a fully intersectional lens. Also, we as researchers are not always ourselves taking an intersectional lens in our own research. And so we are providing them with information that is not intersectional in its nature. So I guess the question is, what advice do you have for policymakers who are writing policies? So I'll go back to Arima first and then come back to Daniela. Thanks, Arima.
Sure, Marsha. I'm trying to kind of little understand the question. Is this the external capacity building of associations or by associations? Whose capacity building that we are talking about?
Okay, so it seems to me that Catherine says that she's from a society in Canada and they do global external capacity building of medical professionals in medical associations. So she's asking whether this capacity building is in effect enabling medical associations to act against these policies.
Yeah, I mean, actually, that's interesting to hear, but, this is something that none of the medical associations actually spoke about, any kind of capacity building, globally. And actually, in terms of capacity building, what they were talking about in terms of what they themselves think they need capacity building is they think that they're very poor in terms of actually strategizing, and they think it's a full-time kind of job, and they don't have the resources to actually hire people for this, some of them were also saying that particularly for this policy, they need perhaps additional training in law in that sense, because they think this is something which is just beyond them, and many of them very senior kind of members of the association, they said the more they tried to read this act, the more they were confused, and they think that law is another kind of a document which you can never kind of get it. So they were talking about actually capacity building to be better at trying to influence policies, is more in terms of how do you strategize, how do you come together, and that's something that they also try to do during this particular negotiation, saying that that the government does not take individual associations seriously. And they said that, which is why it's very important that all of us, all associations need to come together, and why they kind of formed a federation. But something on the capacity building that they have spoken about is that they really need a lot in terms of trying to understand how do you engage with government as associations. Individuals in the associations are very, very influential, and they know how to go about it. But as associations, strengthening the bargaining power of associations is something that, they're also kind of trying to, work towards it. Yeah.
Oh, thank you for that response, Arima. So building the capacity to advocate and bargain for change. Very interesting. Daniela.
This may sound like a glib answer, but I think it's true not only from the literature that we read, but also what you see kind of happen in practice, is that for the presence of political will and commitment is only reflected in action. So if you don't have action, there is none. It's a kind of like you're either pregnant or you're not. So you either have it and it's working and you're having programs actually be funded and supported and actually working, or you don't. I think the nuance really comes into when you start to break out into those little different components, right? If you have the sort of the outward expression of support, how do you then translate that into fully realized commitment by having the actual programs and structures in place and fully funding them? That's the part that I don't think there is enough research on. And there has been some work that's been done, and it's not, as far as I can tell, very well documented in the peer-reviewed literature around some policy indexes. Nutrition has done a few, and PEPFAR, for example, has a sustainability dashboard that looks a little bit kind of like a political will and commitment index. And so that those indices measure the existence or not of certain dynamics or aspects of commitment, but there hasn't been a lot of work documenting how do you then change that over time. And I think that what has happened, at least if you look at sort of this, so I got started in all of this because I had been working in HIV, and you look at middle income countries and they're on their own in terms of sort of donors supporting them. And so they're going to put their money wherever they want. And if they don't want to support vulnerable populations, they won't, right? And in other places where donors are in place and donors are filling that gap on behalf of governments, then when they leave, they're somehow surprised the government isn't going to fill that gap, which, I mean, they weren't filling it before. That's why you're here. So in some places that's changed over time because it has just been time. Social norms have moved, and now it's okay to talk about people who are LGBTQ and that they need services, right? But social norms and some social norms have changed up, for example, to say like needle exchange for people who inject drugs is a reasonable strategy, right? But there is a lot of social norms that haven't changed and aren't going to change without some sort of external pressure, whether that's civil society, maybe it's donors. And I think there's a bigger question there about whether donors should be trying to change social norms in countries. I think mostly we would say no, but when they're doing it kind of becomes a grayer area. or you hope that sort of government and policies kind of move over time. But those things take a lot of time. And we haven't seen any sort of strategies that have been tried to say, okay, this thing kind of helped, other than sort of pressure, whether it's internal or external pressure. I know that's a very unsatisfactory answer.
It is a great answer, Daniela. I think it just speaks to the complexity of a concept like political will. And thank you for that. Inayat, would you like to respond first to the question I posed to you and Tanya?
Sure, thank you. So I think it's a very practical question. And I think there are two components to this question. One is, how do you make research more intersectional? And then the second is, how do you then transfer this knowledge to policymakers? So I think, we need to change the way that we research. There is a push that we see within the research community to have more participatory research. But I think I would take it a step further and say that we need to be not just participatory, we need to be democratic, and we need to be inclusive, and I think we need to move towards working with not just community-based groups, but we also need to involve community-led groups, and that also involves having more representation within the research team, and that needs to happen, very consciously. It's a conscious decision that we have to make. Now, intersectionality is not an academic theory. Intersectionality is a very political theory, and to that extent, I think we also need to move from a purely academic framework of research to also a more political lens for research, and that would involve bringing in more actors. That would involve bringing in more actors than just the experts and the technical academic talent. And I think when you speak to people and when you have discussions and when you have deliberations and when we speak about our experiences, we always speak from an intersectional lens, because we exist at the intersection of various identities. So I think if you have participatory, democratic research engagement at the design stage and at the implementation stage, there is scope to change. So I think we need to challenge these power dynamics within our own research community, and these power dynamics that we ourselves sometimes uphold, and we need to look at community-led groups in particular as equal partners, and not just as respondents or participants or implementers of our research project. So I think there's a lot of advocacy that we need to do within our own groups. And the second thing is, that we do have practical concerns about funding and about donor-led research. So I think the push for this change also needs to happen at at the funding level. So that's looking at research. Second, I think when it comes to how to then take this to policymakers, so like the person who asked the question said, if your research is intersectional and you're taking that evidence, then the inputs that you're giving are intersectional. But also I think it's important to have more players on the table, and that's what I said. Civil society is not a homogeneous body. There are different actors. There are people from various experiences who form civil society. So when we are having consultations with policymakers, the more representative and the more varied the actors at the table are, the more intersectional the policy will be. Thank you.
Thanks, Inayat. Tanya, would you like to come in?
Yeah, great. Thanks, Marsha. Great question. I think for me, I would start recognizing that through our research, we found quite a complex landscape with multiple actors, multiple sectors, lack of alignment, lack of shared vision. I think for me, what I would suggest, as one strategy would be creating a national vision for adolescent health, a shared vision. And that, of course, will require leadership and political will, Daniela. So to step above just the different sectors fighting for spaces and audiences, but really begin to create a national conversation that is really about adolescent health and located within a social and political context. And then to follow that up with meso-level processes or organizational processes, which we can begin to have conversations with policy actors around how we understand gender, how we understand gender beyond just the micro level factors, how we begin to develop analyses drawing on our skills and insights as researchers that focus on meso level as well as macro level gender inequality. and really begin to develop, shared capacities around how we do intersectional analyses, how do we do detailed gender analyses in order to inform policies and programs. So really begin to do that. And there I would say draw on, other disciplines, or draw on gender studies, for example, which has rich literature and experience in this field, draw on intersectionality studies, draw on rich sort of research information beyond health. And I think, again, brokering relationships between health and education, health and social development, again, beginning to look at multidisciplinary and intersectoral action for adolescent health, I think will make all our lives easier rather than just working in silos. And as Inayat mentioned, I think we also need to think about who's at the table. So particularly with adolescent health, moving beyond, just token representation of adolescents, but really, including them as a key actor group through the whole, policy-making process would be a concrete example for me. But I think really, it's an exciting space. There's a space to engage with policy actors. Certainly some reflections that I have from interviews that I've done with policy actors is that they have so little space for reflection that even doing the interviews was a space for them to reflect. So, just again, mindful of the pressures and the dynamics, and the lack of spaces for thinking about ideas that many policy actors face. So I think, again, partnerships and creating processes and structures within an overall vision would be good. Thanks, Marsha.
Thanks, Tanya and Inayat. I mean, I think I guess it's really great that we are able to articulate ways in which policies can be more intersectional. I guess it's just partly about raising awareness, doing things differently, and democratizing the policymaking table. And we are not clueless on how to do this. It's about doing and helping others to do as well. So thank you for that. Kerry, how much time do we have left for questions?
Yeah, I was just WhatsApp messaging you on the side about this.
Oh.
We have 12 minutes left. I think it may be, we could probably either squeeze in one rapid fire round of additional questions, or I could present sort of a closing question for each person to have a couple minutes on.
Kerry, I think you can go for it.
Okay. So this is a pretty open question, and the panelists can also read the Q&A. So if there's a question in there that you just want to dig your teeth into, feel free to grab it for your final thoughts. But just in a general closing, what would be the next steps for work in this area? And this could be a reflection on the future research or dissemination activities you want to do on the topical research you've presented here, like the next study or the dissemination, or it could be more broadly a reflection on the next steps that you see for strengthening this field of health policy analysis. So we can also proceed in the same order, if that's okay with Arima starting us off.
Sure. Yeah, thanks, Kerry, because, it really, in that sense, allows us to reflect on this particular broadly policy analysis, but particularly for this work, because this is something that we have been still kind of thinking through. And that is that, we are currently in the process of disseminating this particular work, in the form of kind of writing for an international journal. And, Bina would echo my kind of concerns is that the tough task that we are facing in trying to convey the complexity of what was happening in this entire policy process, and with what implications, because there's a lot of these questions are actually coming from, on theories of medical associations, which are, in high income countries. So currently, actually, apart from the fact that we would really like to expand this particular work in trying to understand the role of medical associations in different kinds of policy contexts, we are also trying to, think of in terms of a flexible, theoretical framework that actually are derived from empirical insights in kind of, low and middle income countries, if that could kind of accommodate a lot of the kind of different ways that these policies are actually, so messy, but at the same time, there seems to be a certain kind of pattern that also emerges and does justice to kind of, the kinds of context that we are talking about. So right now we are actually in that thinking about this kind of a, thinking of a theoretical framework that could actually draw from empirical insights based on medical associations in low and middle income countries. I just wanted to kind of add here is that, we know that if this was not the policy case, perhaps the, medical associations would have reacted differently. We don't know. On many policy stances, they've been silent, and that silence also is a policy response. And we thought that, now that COVID pandemic, what is basically association doing? We were naturally curious because this is something that, we are doing. Is this an opportunity that they're actually also trying to reclaim? Because some of the associations were so worried that they have lost their legitimacy. The government does not trust them, as an association, not as individuals. So, but is this the pandemic, and are they really doing something? And it's very interesting, and the dynamics are so different, than what we're talking about the case. The case was something directly hitting, what we call the control, both economic control and clinical control. But here, COVID pandemic, this is a chance to talk about, okay, here associations could establish a rule. So I think the point is that we really need more research on a range of policy cases in the sense to understand and theorize the role of medical associate as an important policy actor. Yeah.
Thank you. Yeah, there's that push and pull between protecting their own interests and retaining their legitimacy as positive social actors.
Absolutely.
Mm. Daniela, would you like to comment on next steps?
Sure. So we'll do whatever. We'll write up papers and we'll disseminate. That part I think is less interesting because I'm sure we'll all be doing that. I mean, it's the coin of the realm. That's fine. But I actually think, just thinking about the presentations that were had here, that where I think it would be really, where we need more research is around the policy implementation piece, because I think that both sort of for Arima's presentation, for Inayat's presentation in particular, and maybe Tanya, you can speak to whether this is coming up in your work, is that the issue of accountability is really fraught, and it's either unexplored or underinvested in. I mean, it sounds to me from what Arima's describing that the medical associations in India rose up in arms because now there's going to all of a sudden be more accountability on them. And so that means that there was weak accountability before. And so that's where I would like to see more research, is how these policies get implemented. How do they trickle down? And then what kind of accountability mechanisms are there to ensure that policies are implemented as designed? I mean, and you can then ask questions about whether policies are even designed appropriately, like the work that Inayat and Tanya have talked about, and that don't actually have a comprehensive lens. But that being said, that's the work that I think is really, really important and missing. We need more of that. And there had been somebody in the Q&A that had said, that was asking a question about political will and commitment for like big P policymakers versus small P policymakers. And we've all seen it, right? So you talk to the policymakers who say the right things, or who are maybe like they're switched on, they're into it, let's say they're super into intersectionality, or they're like totally turned on to the needs of migrants or whatever. But when you actually get down, when the rubber hits the road, for the clinician, for the provider, for the person, I mean, we're seeing this in the United States now, right? For the person who is meant to sign up, an undocumented person who is eligible for social welfare benefits and isn't willing to do it, that part, we need to unpack that much better, because clearly having sort of a broad-based support at the highest level is not enough. And so that is what the work that I would like to see. And I'm not saying that I'm going to be the one to do it, but I think that we need to do it as a field.
Thanks, Daniela. And that links back to the opening plenary, where I think it was Kabir who really drove home that point of the policymakers are at all levels, with the street level bureaucrats as well. Inayat, would you like to come in?
Thank you. So of course, like everybody mentioned, there is the plan for dissemination at the academic level, but we also had a plan for disseminating the study by bringing in different actors on this issue, in one room and sort of at one table, and that involved bringing in policymakers, bringing in participants who were part of the research, and also during the research we had come into contact with participants who were also advocating for their respective needs. So they were disability rights activists who were already occupying some advocacy spaces, but of course a lot of that sort of got thrown off the board because of the COVID-19 pandemic. I think what we need is more strengthened partnerships between researchers, between community-based groups, and I think both of these groups bring on advocacy skills and spaces, and I think sort of bringing them together and seeing how these can be leveraged together would be a really important thing to do. Second, I think we require more research on the political economy of decision making from the perspective also of the decision makers, which I understand would come with its challenges because it's difficult to access, and I'm sure they would also be limited in terms of how much they can engage. And I think and I think we need to we need more research on the whole process of advocacy, for formulation of policies, and also, like Daniela mentioned, looking at what's happening at the implementation stage, and like I said in my presentation, a lot of the accountability frameworks and implementation frameworks are missing in the policy. So I'm curious to know, that once the policy is sort of finalized and sort of notified, then how do you sort of take it forward for implementation when there is very little to guide you, as to what are the entry points for engagement. Thank you.
Thank you so much, Inayat. And Tanya.
Okay, I have 2 minutes.
Yes.
I think just building on the conversations we had last week and reflecting on COVID, for example, what I've been thinking about is, given the context that we're living in, COVID has made visible the pre-existing inequalities. And I think for me, it's once you see them, you can't unsee them. So again, to foreground power relations, inequality, exclusion. So it's really, I think as a field, it really foregrounded, for us, the importance of doing more research that centers power analyses and all the joys and challenges that come with that, and all the actors. I think it's really important. And I think also, this year is 25 years since Beijing Platform for Action. And I think there's a wealth of analysis that we can do in terms of, what have been the successes and what have been the challenges around integration of gender at different levels, global level, national level, different contexts. How does a concept like gender mainstreaming, for example, become contextualized in South Africa, in India, in Malaysia? What does it feel like? What does it look like? What are the processes? What are the challenges? What are the politics around that? So I think, some of those reflections were shared at the World Health Summit today. Asha and others were part of the BMJ, special focus on that. So I think there's lots of research, there are a lot of relationships and partnerships we can build with others interested in similar issues to us. So for me, definitely, I would advocate a stronger integration of gender analyses, as I mentioned, beyond just the micro level, but to use sex disaggregated data as a sort of trigger for more deeper political analyses, which would definitely begin to focus on intersectionality as well. And I think also just the last point, Kerry, I think last week we began to talk about our own positionalities and knowledge production and relationships between, power relations between researchers and various other actors, the power relations within the global north and the global south. And so I think, again, some papers that really talk about positionality and some deeper reflections, would really strengthen our contribution as a field. So I'll stop there for now, but this has been really exciting. Thanks so much.
Thank you so much, Tanya. Yeah, and that final point does reflect a question we got about our own reflective process in doing this work. So we'll close here, but I just wanted to thank everyone so much for attending. Thank our incredible panelists. Thank Fong behind the scenes and Marsha for handling all the discussion. And note, please do consider registering and coming to our future sessions. All information is on our website shown here. With that, I'll close. Have a great evening or day, wherever you are. Thank you.
Thanks,
Thank
Kerry,
you,
and thanks,
everybody.
everybody.
Thank you.
Thank
Thanks,
you, Kerry.
Kerry,
Thank
and
you,
everyone
everyone.
else. Thank you.
Bye.
Thanks for coming.